Ann Overhoff from Ross Memorial Hospital in Lindsay. And Ann is going to talk about using HOBIC data to examine seniors' mobility within an acute geriatric program.
Thank you for this opportunity to speak. I'm Ann Overhoff. I'm the Director of Critical Care and Medicine at the Ross Memorial Hospital in Lindsay. And it's located in the city of Kawartha Lakes, which is not too far from Campbellford, actually. We're in the same lane. I guess it's probably about an hour and a bit to drive, I think, Diane. Not quite sure. But so we're close. But we are considered a large community hospital, even though I wouldn't consider it large. It's 200 beds. And we have a large emerge volume, though, 46,000 come to emerge a year. Really, really busy in the summer. Our numbers really surge in the summer. But as Diane was saying, we do have a very large senior population. And actually, with the city of Kawartha Lakes and the Peterborough area, which is our neighbor beside us, we actually have the second highest senior population in all of Canada outside Victoria, BC. So when we're talking about seniors, we have to talk about seniors. So interesting, when I was asked to do this presentation, I really didn't think I would be up here speaking. It was right after Christmas, and remember, I'm the Director of Emerge, Medicine, and ICU, and Infection Control. So what happened right after Christmas? The influenza surge. And on top of all that, it was my week to be administrator on call. So besides, having a 70% increase in volume in our Emerge department over the holidays, opening every spot we absolutely could in the hospital, I was on call. So there was a message left on my answer machine by Peggy saying, would you mind, doing a little talk? And it was just a couple of slides. And I ignored it for about a day or two. I thought, oh my God, she's going to think I'm ignorant. I better just send her an email and say, okay, yeah, I'll come in and do that. But didn't really give a lot of thought to it. And next thing I'm getting these emails from Penny saying, can I have your bio? Can I have your bio? And I'm thinking I ignored that too, because I'm really good at ignoring little detail things. And lo and behold, I opened it up and just about died when actually I had volunteered to speak here at the symposium on HOBIC. And I don't know, sort of what Dottie was speaking is that our nurses aren't that great at always completing the HOBIC, so I'm always a little bit nervous about our HOBIC data. And then when I opened up and saw all the ISIS folks and all the PhDs, a couple of my professors from UFT, I really panicked. But I'm really glad that I'm up here because, I am the HOBIC coordinator for our hospital, and, you really have to understand the data, and sometimes it's these opportunities that really make you dig down into it and take a look at it and see what it can actually do for your organization. So I am glad that I'm here. So I'm going to talk a little bit, even you can see the title on the syllabus is different than what I actually am going to talk about, because after when I started working through it, I thought, nah, I didn't like that topic. So I'm going to be talking about Home First and the Geri Acute, quality transition of care for seniors. So this was a partnership. Now CCAC is our access center, but we also have community care in our area. And I'm originally from Brantford, so when I moved out to Lindsay, I got really confused with the terms. But community care is a bit separate. They help us with our wraparound. They help us with our patient transports, where, of course, CCAC is your access center. And we worked very closely with our LIN on this project. So we had a problem, and it's no different than most of the large community hospitals. We had a problem with our emergency department performance. So for instance, in our emergency department, you had a better chance of driving to Vancouver than what you had to get out of our emergency department to an inpatient bed. So we were sitting around, the 50-hour mark. So we had a problem with that. Problem with our seniors' care, adverse outcomes, falls, delirium while they're in hospital, deconditioning them. Inappropriate utilization, so people being there too long, long length of stays, and lack of access to long-term care, and of course, suboptimal coordination of health systems. So who's really the navigator in the system to get our patients back to their home? So what I'm talking about here, that I'm going to look at our HOBIC data, is actually, it was two programs that came together. So the Home First philosophy, which we've heard a little bit about here from the previous speakers from Alexandria, and the Geri Acute program. So the Home First is basically, we want to get these people to wait at home, the long-term care folks, our seniors waiting at home where they can make the best decisions for their care instead of making bad decisions in the hospital. But to get them home, we have to make sure we condition them. But to give you an idea of our ALC problem, the acute care floor that I'm over is 41 beds, and when I came in 2009, one whole end of it was for ALC patients. So we lost 15 acute care beds to ALC patients. Doesn't help with flow, so no wonder you have a 50-hour wait in the emerge department. So what was the Geri Acute program? So the Geri Acute program is actually some money that was given to us from the LIN to trial a wraparound service. So we call it a wraparound because we trained some core staff to work with our over 75 population that had risk of not getting back home. So it was a geriatric nurse specialist, a physiotherapist, an occupational therapist, a physio assistant, and a reactivation therapist to support these patients. So what they did in the morning is they identified these patients, they went to the bullet rounds, they worked with the team, they did baseline data, they did discharge data, they strengthened them while they were in hospital, and they would go from our 4 acute care units. So we had 2 programs, 2 objectives. The 2 objectives were decrease patients waiting for ALC. We need to get them out of the hospital waiting at home, free up our acute care beds, and improve our quality of care for seniors. So actually, did it work? So one of the first things we looked at was, did our ALC volume go down? I know it's a little bit hard to see, but the green is what our ALC volume was before, and the blue is where we had come down. And actually, during the summers now, I actually have 0 patients waiting in my medical floor for ALC. So it really did work. But we wanted to make sure that we weren't sending patients home and having them decongestioned and not doing well at home and coming back in. So what data did you look at for that? Well, we have the HOBIC data. It was perfect. So we looked at the ADLs, and ones that we noticed the biggest change in was our transfer toilet use, transfer toilet, and our mobility. And when I took this data to Peggy and to Dot in 2011, because we were actually asked to go to the IHI conference in Orlando to do a poster presentation. And for me, it was really hard to interpret the data, so they told me it was really good data, so we went with this, which was great. So the bed mobility was the one we noticed the biggest change on. Now, I don't have percents, and I'm really glad to see that we are going to have the percents now. But I just put looking at the changes in our values from admission to discharge. For the first 6 months is before we implemented the Geri Acute in the home first. They actually launched at the same time. And the last 6 months is the post-Geri Acute in the home first. And you know, just for value indicators, there was an improvement of 5.5. So we're really pleased to see that. And our readmission rate, of course, that's a really good indicator. It really dropped off nicely. So we're really happy with that as well. So when I was asked to do this presentation, I thought, okay, so what can I elaborate on from what we did in 2011? So I remember hearing some changes on the Geri Acute program. So I thought, well, gee, wouldn't it be neat to maybe run some data and see if the changes they made with the Geri Acute folks, if it actually had improved the quality of care that we were providing to our patients. So we had moved from what I called a nomadic model. So the special Geri Acute group that were the elite, they were the specialists in the hospital, went from the 4 units to actually training the physios that were actually on the floor and the OTs to become sort of the extra Geri Acute specialists. And it was really interesting. And the reason they went to that is they actually thought they were spending too much time on a report and not enough time with patient care. So they thought if we had 4 different groups doing it, we would have better outcomes. And then I pulled up this, because you can run it by age, of course, as an indicator, and it was the first time I had seen red data. And I mean, I don't know a lot about data, but I know when you see red, it's really bad in HOBIC. So I actually called the geriatric nurse specialist to my office. I said, you know what? I said, I ran your data, because this just started, the change started June of 2012. So I ran the data from June to October, and I said, you know what? It's not looking so good. It was much better the way you had the program before. And her answer to me sort of validated it, which was nice to see because our numbers weren't really high. And she says, yeah, you know, we were sort of suspecting that. And if you think about it, it makes sense. Because if you think of the stroke model, for instance, with the specialized stroke beds and the specialized training, they have 30% better outcomes. So really, with our specialized geriatric model they really had some ownership and accountability and really experts in it. And you can see why we actually had better outcomes. So based on this, we have two decisions to make. We can go back to the nomad model we had before, or can we invest in more training to the groups that are on all the different floors? So because of HOBIC, we wouldn't have been able to tell this before. We could have just sort of guessed, and we've always done that in healthcare, haven't we? We've sort of guessed our nursing and where we're going. But now we actually have data that we can really say, you know what? This is really proof is in the pudding, right? And us as leaders, we can actually really start to use the HOBIC data. And as I said, I was really glad to do this presentation because it really made me think again of what's really available to us to make these decisions. So actually my learning going forward is when I actually had done the first session with the IHI poster, I did make sure I went back to the staff on their education days and shared the data. And actually I thought I was going to get hammered because it was really the first time they saw data. It takes a long time to do it, but they were really glad to see it. So it really reminds me again to get back out to the frontline staff. Like, we struggle at our hospital because we're not electronic. So this is the only thing we have electronic. So the staff really struggle with their passwords, and when they leave it, they lose their place when they're doing the assessment and come back in. But we really need to spend some time with the staff, and we have re-educated, but I think it's worth going at it again for them and really coming back and showing the data. But really going forward, it really helps us. Like right now, I'm sure most of you are planning your goals and objectives for next year. I mean, this is our opportunity to really use the data now. I mean, the therapeutic itself, the dyspnea, I mean, we're all going to be, I'm sure, doing goals on COPD and congestive heart failure. So this is our opportunity to start using some of this data. So, of course, I've put our little, if you can't tell what that is a groundhog. And I've put a little thing of drive safe. Is there any questions? Thank you.
Because we always worried about those reports because there was so much data in them, and we rejigged those. But having the red and the green in terms of green for the improvements, just
yeah, it comes right out at it. Yeah. And I mean, the other thing I noticed for sure too was the therapeutic self on our medications. And I know we have a lot of work to do on our discharging. So again, it's right there. It's everything that we're hearing from the ministry. It's here. Okay.
We did not tell these folks what to say.
No, that's true. Okay. Thank you.
Okay.